So 20 minutes talk, and then we'll have 5 minutes discussion after that, and we'll squeeze in the time from the fellows talk a little bit. That's what we decide now.
Acha, can you guys see my screen?
Yes, we can.
Acha, good. Acha, first of all, I would like to thank all the amazing organizers and the panelists for joining us, and all the attendees. I know it's pretty early, even for Pakistan time as well. So we will go straight to the talk because our time bada thoda. So obviously the talk is about calcified lesions. So I'm gonna. So this is a case from one of my colleagues at Mount Sinai. He's mainly a peripheral interventionist, like this is a coronary case. You can see it looks like a pretty straightforward type A kind of a lesion. But what you need to see also and appreciate is that there is a good bit of calcium, probably at least on one side of the vessel wall. Probably I think we do such kind of cases day in and day out in Pakistan as well. And I think a lot of times we try to get away with just balloon angioplasty. So this is what he decided to do. This is the PTCA with a pretty good 1-to-1 size and C balloon. You can still probably see a bit of a dent in it, but something that not a lot of us will consider of as much of a hindrance. So this is the image after the PTCA. Looks pretty reasonable. So they decided to stent it from the ostium. Stent position looks pretty good. They stented it. I think the arrow has moved a bit, but like, so there is a bit of stent under expansion at that particular point where the balloon wasn't really expanding. So they looked at it. They thought we need to probably post dilate also probably at the ostium as well. So this is the image. Looks like the stent is not really expanded in the proximal part. So they decided to PTCA. This is the PTCA balloon. They didn't really save the PTCA, and this is what you sort of get after trying to expand this sort of a lesion without actually treating it in the more recommended manner. So this is the image after covered stent, and also you can see the pigtail in the pericardium. It was frank perf. So patient did okay, like he stayed with us for a few days and then went home. But obviously we need to learn from our mistakes. And when we were discussing this in the M&M, that particular person was not used to using rota, and that was one of the reasons why he decided to not rotablate it. So what are the issues we see with calcium in our lesions? And I think the way Professor Nauman Naseer has done the introductory email, sent the introductory emails and everything, that calcium is kind of the Achilles heel of intervention for all of us. And we all know, especially mashallah, the August gathering of panelists that I have that were amazingly experienced, that we always underestimate coronary calcium angiographically. It responds poorly to angioplasty, difficult to completely dilate, prone to dissections, perforations. It's hard to deliver stent through it. May prevent adequate stent expansion, which leads to stent thrombosis, stent malposition, and also we have a lot of data around to suggest that if you have a malposed or an underexpanded stent, there is uneven drug distribution, which leads to earlier restenosis than expected. So what do we know? How do we classify it? I won't bore everybody with it, but in terms of calcified lesions, the ACC guide classification is they're classified into two, type A and type B. Type A has two components, subcomponents to it. The none where there's no radiopacity on angiography, and then mild is where you can see faint radiopacities during the cardiac cycle. Type B has moderate and severe in it. Moderate is when you see dense radiopacities during the cardiac cycle before contrast injection. So that's probably what there was in that case that we just showed. And then there is severe calcification where you have tram track appearance and you can pretty much see both sides of the vessel wall without cardiac motion before the contrast injection. This is pretty much the same. So obviously we know angiographically we underestimate it. So what other tools do we have? I think IVUS, a lot of laboratories in Pakistan, cath labs in Pakistan have it now. OCT is also present in a few of our labs. And I think wherever possible, wherever feasible, and wherever most importantly affordable, we should probably use these whenever we can, especially if you have any doubt regarding calcium, because calcium is one thing which I think, other than geographical miss during angioplasty, pretty much every other complication can happen because of if you miss moderate to severe calcium in a lesion. So there is obviously not there's no definite data about everything regarding calcium, but whatever we have, I've just tried to present it. So this is a paper from Veronicus et al. And published at in CCI in 2001, where they showed that with the increasing degree of arc of calcium on IVUS, the stent expansion goes down. And that was early 2001. And I think all of us would probably agree with it, that this is what we see in our daily practice as well. So this is a registry data published in AHA in 2015, about 12,000 patients. And what they saw and what they observed were that there are some predictive risk factors, which if you have them in your patient, maybe you should be thinking about calcium before even you do the angiography. So obviously with advancing age, Hispanics, not that much of an issue in Pakistan, but in US, whoever is working in US or is working would understand and agree with it. Anybody on dialysis or a low EGFR is more prone to calcium. Peripheral arterial disease, diabetes, history of MI, lesion length. I think that is one thing which I keep telling my fellows as well as my lab staff, that whenever you see a long lesion, you should always be thinking of calcium in it. And so I would always do a couple of dry scenarios. Like obviously IVUS is not, we have IVUS, but it's not very affordable for everyone. So that's one thing that should alert you to the presence of calcium. Left main and then thrombotic lesions sometimes can also have it. So this is a paper from Greg Stone et al., which was published in American Journal of Cardiology in '99, where they showed that if you have a significant degree of calcium at the regular stent expansion pressures, where most of us would use 12 to 14 atmosphere. And then if you have calcium in these patients, you only achieve adequate stent expansion in about 66% of these patients. Even at 18 atmosphere, and I would doubt that a lot of us use 18 atmosphere in our stent, with our stent balloons. Even at that, only 2/3 of the patients achieve adequate stent expansion. So that is something which is an eye-opener, and which should be an eye-opener for people who don't consider calcium as much of a problem. So this is the data from Equity and Horizons AMI, where they it's a sub-study based on lesion calcification. And what you can see in this is that all various types of MACE go up proportionate to the degree of calcium in the lesions. So what do we have to treat calcium? Once you have recognized it, obviously, we need to look into our toolbox and see, just like Professor Nadeem Rizvi said, that not all the labs are equipped with everything that is needed to treat the calcium. And so probably we need to know what sort of artillery we have and ammunition we have that we can throw at it. So my training was at Mount Sinai, and I worked for my initial few years as a consultant at Sinai. So this was the practice we did. And the reason I'm saying we did is because everybody has a different experience, and that's the amazing thing about interventional cardiology. So we would hear about everybody, all the other panelists, what they do. But this is what we used to do: mild to moderate calcium, try with a non-NC balloon, short, try to keep it short. Like if I don't have money for rota and things like that, we'll probably use just an 8mm balloon to put a focal pressure on that particular point where you're trying to break the calcium. You go to high pressure inflations, and then NC balloon with another wire side by side. Sometimes I would put even 2 wires side by side, and then go for high pressure inflation. Cutting flexstone balloon. Now we have Wolverines. Angiosculpt or chocolate balloons are scoring balloons. So they are basically more compliant balloons with 3 018 wires wrapped around them. And then for severe calcium, you have rota, you have orbital atherectomy, laser, shockwave, and then I know in Pakistan there's some facilities use Opn balloon. Like it's not FDA approved. I have not used it, but I will mention it because it's available. And then you can use these techniques for bailout as well. I'm just going to quickly mention. So Wolverine is one of the newer entrants in Pakistani market in terms of cutting balloons, and it's made by Boston Scientific. So Flexstone was a bit hard to deliver, and what they have done is they've made the profile a bit smaller, so it's more deliverable, and especially for osteal side branch lesions, I think it's an amazing tool to have if you can have it in your lab and if it's affordable for the patient. So it cuts the elastic lamina. We won't discuss that. So orbital atherectomy is also available. I think a couple of cases were done in Pakistan as well with it. It's easier to use. I think it's compatible with 6 French. It's a faster learning curve, and everything is in the hand. So in US, I know for a fact that its acceptance is it's very popular, and especially the newer interventionists coming out in the market who don't have much experience with Rota, they are finding it more comfortable to use. And I think that was one of the main reasons why Boston had to come up with Rota Pro. That's a different talk, so we'll discuss that sometime. So it Urdu mein agar kahin na, to it's more like a regmal, so it would break the calcium in areas where there's resistance to the movement of the actual burr. And then the good thing about it is the fact that the incidence of slow flow is much less as compared to Rota. And one of the reasons is that the average particle size it generates is smaller than the red blood cell. So it gets easily absorbed because 99% of these are smaller than the capillary diameter. So that's one thing we need to know when we are talking about these atherectomy lesions. Then we have laser. I know a couple of places in Pakistan have it as well. So it works in multiple ways, photothermal, photochemical, photomechanical, and that's a different talk. So I'll leave it to that particular talk. And then lithoplasty, I know it's, while I was in the US, I had the experience of using it in the peripheral world because it wasn't FDA approved for coronaries, and we used to use it for TAVR and stuff. It's pretty, it's not that hard to deliver the balloon, maybe not for the balloon uncrossable and undilatable lesions, but wherever it can go in easily, it's an amazingly safe tool to have. And probably once it comes to Pakistan, I'm sure people will find it not that hard to use. So this is the Opn balloon. It's a 2-layered balloon which can go up to 35 atmosphere, even higher, where people have used it up to 40. So, but I don't recommend using it because I think it, to me, it probably can cause more perforation than dissections and stuff. So, not something that I feel recommending. So we'll talk about Rota. So it's a diamond chip, microchip burr, where probably the distal half of the burr is made up of diamond microchips. It causes differential cutting, and then we can use it in for multiple indications. Obviously, the top of the line is calcified lesions. Then we have undilatable lesions, long diseases, smaller vessels. We can use 1 to 5 burrs. In-stent restenosis. I know it's a bit of a debate where some people don't like using it, but I have very good experience with it, and I haven't found any issues with using it in stents. Bifurcation lesion and then osteal lesion. So what are the issues that come up with it? Obviously, slow flow, I think, is the most common one. Then perforation, thankfully, is not that common, but it does happen. CKMB release. I think CKMB release is not really important for the Pakistani market, but in US, and I know especially in New York, you need to report any CKMB release more than 5 times normal post PCI. And even if you have a successful rotablation case, if your CKMB release was more, it's counted as a complication. So that's something, again, which favored use of orbital atherectomy, wire bias and dissection. And then I think it's a bit more technically challenging than OA or use of laser. So what equipment do we have? I think the first thing, obviously, with all intervention is our medium, or the tool that which is used as a rail. So we have 2 wires widely available, and even in Pakistan we have this extra support wire. So the main difference for people who don't use it much is in 2 particular components. One is the front part, which is the more floppy spring tip part. It's a bit longer in the extra support wire, And also the more firm part, which is the supportive part, starts much earlier in it. So this floppy part helps in the more tortuous lesions where you don't want the vessel straightening, and then the stiff part gives support to the burr. For me, the main uses are in the osteal lesions, or sometimes in ISRs. I use it, but I think majority of the work can easily be done with your rota floppy wire, and it's a pretty good tool to have. And I think majority of the time you don't really need the extra support wire. How does it work? Differential cutting and orthogonal displacement. So whenever I go for proctoring, especially in a couple of hospitals, I always get asked this question: said, if you are rotablating the mid LAD, so the rota burr goes through the prox LAD. So what happens to the proximal LAD? So if your vessel is healthy, it won't really do anything to it, because it only displaces its momentum in areas which are non-elastic. So healthy vessel is supposed to be elastic. Non-healthy vessel will not be elastic, and that's where it will give resistance to the burr, and that's where it should rotablate. This is just an example. If you're just using a simple PTCA balloon, you will get this irregular sort of a deformed lumen at the end of it, whereas with rotablation you get a very nicely trimmed out lumen, which looks pretty ideal for stent placement. This is just the IVUS data showing the same. So in terms of tips and tricks, so this is my method of doing it, or mine as in how we do it in Mount Sinai. And I would love to hear what others do. So first thing we would do is outside the body, once you have the rotablator on the wire, you need to make sure the drip is on, which is the rotor flush, and the clip is on. I set the baseline RPM ideally outside the body. So we went to Turkey a couple of weeks ago for the proctor meeting, and I was surprised to see the local proctors. They checked the speed in the guide actually just before the lesion, and whereas I was trained to check it outside the body. So I think both methods are acceptable as long as you're not checking inside the lesion. Burr size, majority of the work I think can be done with burrs from 1.25 to 1.5. Sometimes you have to use 1.75 burr, and 2 O's and 2.5 maybe very rarely. So optimum speed, we use 150 to 160,000 as optimum speed. Sometimes for a smaller burr, like a 1 to 5 or something, I might go up to 180, but optimal speed, recommended speed is 150 to 160,000 RPM. You should always be thinking about slowly advancing the burr. So all these books, all the cases that you see around, they use this word pecking motion. And I have had the chance to work with a few colleagues in various hospitals in Pakistan and abroad. And I feel that everybody interprets this word pecking differently. Somebody is bringing it all the way back from the guide to the lesion, and they call it pecking. I call it hammering. So it's pecking should be small movements, a few millimeters front, and then you bring the burr back a few millimeters, and then sometimes you have to let it work on the lesion for a few seconds, maybe up to 5 seconds, and not keep bringing it back. So that comes with experience, and I think everybody's experience is different. What we should do, which is based on data, is that you should maintain less than 5,000 RPM deceleration from the baseline for less than 5 seconds. So if you hear deceleration with experience, you can just listen to the sound of the burr and you can figure out that it's decelerating, or somebody should be looking at the speed and letting you know. If it is decelerating for more than 5,000 RPM, you should not let that happen for more than 5 seconds. Ablation time in one run should be, we would not ablate for more than 20 seconds. You should always pull back intermittently for coronary perfusion or to check for perforation, but like not always. If your blood pressure is holding fine, probably just wait for a few seconds between each burr, and then between each run, and then keep going. So some of the technique cautions that I see some of the people mistaking on is they always over tighten this advancer knob. So you check everything outside, you go in, and everything is ready for rotablation, and then you start sinning or fluoroing, and then you have tightened the knob so hard that you can't really open it. So make sure it's all within your physical power limits, and it's not something that somebody's going to break or pull from you. So tighten it to a degree that you can open easily. Avoid dottering. That's something that you should never do, because your rotabur might go forward through it, because remember it ablates at the front, but it might not be able to come back from the lesion because there is no ablation ability at the back end of the burr. So never stop burring the lesion, which is a big no-no. So what we would always recommend is that you keep the systolic blood pressure in triple digits. So during the burr run, if you see blood pressure dropping, I would always stop, bring the burr out into the guide, try to stabilize the patient hemodynamically. Majority of the time is because of a bit of slow flow, and it recovers within a few seconds, and you might need to give them some vasopressors. But if it does not recover, you should not continue with the burr, and just pull out and take a picture and see what's going on. Even if you have a temporary wire, so again, a lot of operators do not use temporary wire even for RCA runs or dominant cert. We would always use it. So, but what we would always recommend is that if the patient becomes temporary wire dependent in the middle of you burring the lesion, you should still stop. Let the patient regain his normal rhythm and then continue. For the final polishing run, I think the two big things that you need to notice is that there should be no RPM drop, and that you should not feel any tactile resistance when you are rotablating. So how can you avoid it? So I think one thing which I always tell my fellows is that better than avoiding is when you plan for something and you don't even let that happen, is better than actually treating it. So when you see a long calcified lesion, or you're trying to rotablate into a chronic total occlusion, right coronary arteries, somebody with poor LV function, or somebody who is hemodynamically unstable, or if you're doing it in a thrombotic lesion, it's not totally contraindicated. If you cannot balloon dilate a lesion, you have to do something to make it yield. So you can do it, it's not recommended, but if you're doing it, you can obviously expect slow flow. So what are the mechanisms? Various mechanisms, all out in data. Impaired local sensor, EDRF, that's one of the EDRFs is nitric oxide. So when you have endothelial dysfunction, we know all these factors are already there in the lesion. So it's not always your technique, but it's also the local factors in the vessel wall, as well as how the LV is, that actually dictate if you are going to have slow flow or not. So if you know them, it's something that you can predict, and then maybe you can keep shorter burr runs. So one of the things that is particularly important clinically for me is somebody with low EF, high LVEDP, and when they have a lowish blood pressure, you know that their epicardial vessel pressure is going to be low and the EDP is high. So these patients are the ones which I feel are going to be very prone to slow flow. So maybe these are the ones we can try to improve their hemodynamics a bit better, maybe give them 80 or 100 Lasix even before you even start rotablating, get them catheterized, get the blood pressure up with some sort of hemodynamic support before you actually start the procedure, not in the middle of the procedure, because they don't give you much time. Once they go down, these sick patients, then you don't really have much room in what you can do. So we don't have data, as I said, for everything, but what we know from the data, there was a Stratus trial which compared essentially aggressive burr sizing to regular burr sizing. So in the aggressive burr sizing group, they sized the burr sort of 1:1. This is burr to artery ratio of 0.9, which is sort of 1:1 with the artery ratio. And then compared with the routine strategy where burr to artery ratio was less than 0.8. And what they found was give significantly higher incidence of slow flow in patients where you were using a bigger burr. Again, predictors of CKMB release, they found the most prominent predictor was deceleration more than 5,000 RPM for more than 5 seconds. And then predictors of restenosis afterwards was deceleration of greater than 5,000 RPM in the polishing run. And then they found that LAD lesions were more prone to restenosis. So that's what we recommend, current burr to artery ratio of 0.3 to 5.5, and majority of the time it does this job. So how do you do it? That's what I would recommend: small initial burr sizing and small upsizing if you need it. short ablation runs and avoid RPM drop, avoid hypotension and bradycardia, as we said, keep the systolic blood pressure in triple digits, rotaglide. So I was surprised to know, I thought it was a Pakistani thing that we did not have rotaglide in Pakistan, but I went to Turkey and even they did not have it. So it's probably just available in US. So essentially what it has is a lubricating solution, and probably albumin forms a major component of it. So one of the Desi totkas is using Propofol. So Propofol has albumin in it, and I have been putting Propofol in my rotaflush, and it has it lubricates the whole system. So I feel it makes my runs more easier, in addition to your regular cocktails of Rapamil, Nitro, and heparin. So perforation, again, probably the most horrendous thing that can happen during intervention is perforation, and I think we all are afraid of it. So what again, if you are able to predict it's going to happen, maybe you should avoid it or use some other strategy for it. Lesions in a bend greater than 90 degrees. The other day we had a lesion, I don't know if Asad Salim is in the audience, but like we had a patient with just isolated LAD lesion, and patient had actually 290-degree bends in her LAD, and both were severely calcified. We could not even get a 1O balloon or even a microcatheter across. So we decided not to rotablate it, because I think you can be Rambo and try doing things, but if you have something, patient who is low risk can go for surgery. Sometimes saying it should not be done is actually better than doing it and then repenting it. Severely eccentric calcified lesions, large blood-to-water ratio, CTOs again. So technically, small initial burst size is always your friend. Avoid. So one thing I do, and what we were taught, and how I taught my fellows at Sinai as well, and all during the training session, that the initial first pedal that you put just before the lesion should be on the Dynabar. So you have set the speed at Dynaglide, and then after you have taken all the resistance out of the system, once you have put the burr in the guide and you are ready to burr, the first pedal should be on Dyna. So if the burr is going to jump, it should jump at a lesser speed than actually at full speed, and that avoids dissection and perforation, and in more manners than you know. So that's one thing that's a lifesaver, and I think that's one thing I'm going to recommend to everyone. Again, rota extra support wire in these osteo lesions and where you feel it might jump or it might bend is something that you can consider. This was the data. So we're going to show our data. My fellow is going to show our Shifa data. So this was our Sinai data, where we realized that over the years, things that that helped us improve our outcomes. We do the highest number of rotablation in US for a good few years, and what we found was reducing the speed to 140 to 150,000 RPM using a rotaglide and keeping the burr to artery ratio around 0.5, and then obviously the invention of drug-eluting stents helped it. So these were some of the things that helped making our procedure safer. This is just a case I'm going to show, and then we'll go to our fellow. This was a pre-rotablation case. You can see a lot of calcium. So this was post-rotablation, and this we did an OCT. You can see the cuts it made to the calcium, and then we were able to get a good stent expansion. And this is post-OCT, which shows adequate stent expansion and apposition. So just to conclude, calcified lesions are the Achilles heel for sure of intervention. They are definitely underappreciated. They can cause all sort of complications. In complex coronary cases, I think optimal stent procedural techniques should be undertaken. If you don't have that equipment or expertise, maybe it should not be a case that you should be doing. And the use of atherectomy, I think it cannot be stated enough, especially when you're dealing with anything more than moderate calcium. I think it always helps and also reduces the chance of perforations. Again, ideally, we should be doing it and combining it with imaging. But if you can't image, at least the angiographic criteria should be in your mind, and also the predictors that we discussed. If you have those in mind and angiographically you have a suspicion, maybe it's something that you can discuss with your colleague who deal with calcified lesion more frequently than you, and then to make your procedure safer. Thank you.
Thank you, Asad, for an excellent talk. It was a really nice overview of everything that we needed to know about quota. So we are joined by our panelist, Dr. Farqad Alamgir, who is very well known to all of us for his especially work in MitraClip, and also has been a proctor for rotablator. And we have Dr. Osman Faheem here, who's Chief of Cardiology at A Khan, and also an experienced interventional cardiologist, does a lot of rota work. So we'd like to, and I don't know if Dr. Asad Pathan joined us or not. So we'd like to both he's here as well. Dr. Asad Pathan is Director of Cath Lab at Tabba Heart. So we'd like to hear comments from our panelists as well. Dr. Farqad Alamgir, if you could unmute your microphone and give your thoughts.
Excellent talk, Asad. Just a few things. One is, the reason why we don't do enough rotablator in Pakistan is really, one, most important is the cost. Two, the availability of the equipment, and तीसरा जो important चीज है वो है कि setting up the whole thing. Say in case you need it, in a case where you started with ordinary, plain balloon angioplasty. So I think ये जो cost issue है, that's the one which I think most people would face, because and so this is why I think it is so important that procedures that we don't do frequently, we actually pair up for those procedures. We offer our services, or people who are more experienced should be there to reduce complications. And just a little brief comment on the rota solution, Rotaglide. In America, yes, I know that they are using. A lot of people use that, and they've given up on this. But for Pakistan, it is still something that we are using. So this thing about you mentioned about Propofol, I haven't heard that before.
In India, they use it everywhere. So actually, when I was coming to Pakistan, Dr. Shamin Sharma actually told me that that's one thing you can use. And actually, it has albumin in it, so it works amazingly. So you just add 1 to 2 cc in your rotaflush, and it's actually a very good lubricant. So it actually helps.
Interesting. Yeah, that's the first time I heard about the Propofol as well, but interesting thought. And you've used it quite frequently, routinely in your cases, huh?
Every case.
Oh,
and if you have, femoral access sheets that are very calcified, even if femoral access is very calcified, and if you have sheets that are tough to go in calcified femoral vessels, if you put a little bit of Propofol in it, it'll go much easier, and your equipment will go easier through it. We use it frequently during TAVRs also for bad access.
So, Usman, your thoughts?
The fantastic talk and a great overview. I think very relevant for Pakistan, despite the cost limitations. It's for busy labs. It is somehow the economics have to be worked out. It's a tool that's required, and somebody in the lab, at least one person, should be comfortable with it, so that they can, like Dr. Farqad Alamgir said, they can be there to support the other operator. I think a couple of things. There's some idea about the 1-5 burr being a little more prone to getting stuck. And we didn't talk much about stuck burrs and how to troubleshoot that. But the shape of the 1.25 millimeter burr is more flat. And the burr, the diamond coating is only on the front, not in the back, and it tends to jump. So initially, if you're going to use it, be very careful, like Dr. Asaad said, using the 1-5 burr. If it jumps ahead of the lesion, then bringing it back, it may get stuck. So using Dynaglide to position it, doing your slow movements or pecking, and not be too aggressive up front. The second thing, which I found personally challenging using Rota in Pakistan, is larger vessel with very severe focal disease or nodular calcium. So say you have a 3.0-3.5 vessel and it's a 90% focal lesion. Even with the 1.25-1.5 burr, you're still going to be left with residual focal calcified stenosis, which may not yield with your balloon. And then you have to think about using a second burr. If you size a more aggressive burr, then you're more prone to no reflow and site complications. So that's where, if you have a larger vessel with a very severe stenosis, heavily calcified, factor that into it, that, one burr may not be sufficient and you may have to use 2 burrs, and that, goes overall into your cost and procedure time, and think about, whether bypass is a better option. for there. But great talk. I think Asad touched on all the important points.
We have Dr. Asad Pathan from Tapahat here with us as well. Could we have your thoughts as well?
Yeah, I think an outstanding presentation. You can hear me, right?
Yes, we can.
So I guess just a few thoughts, I think, about the cost. It's ironic that the Wolverine right now in Pakistan is nearly the same cost as a rotablator. So just to put things into perspective. And I think what was mentioned about burr getting stuck and jumping forward. So I think for the beginner, it's very important that at the beginning you loosen the advancer knob, make sure there's no forward tension, loosen your Y connector, make sure there's no forward tension on it so that it doesn't jump forward. And I think initially going in with Dynaglide, again, for the beginner, it's confusing. It's important to come off Dynaglide before you start burring. I've heard of operators starting burring while on Dynaglide, and you're more likely to either get stuck or have no reflow. And I think that's the final tip, which I learned from Bilal, avoiding TPM, intracoronary aminophylline. It works very well for bradycardia related to rotational atherectomy. And since we've been doing that, we've not put in TPM for any of our rotablators. But otherwise, I think Asad pretty much covered everything else. So.
Thank you. Great comments by all the panelists over here. So can we go ahead with the fellows presentation?
Sir, we have some questions in the question and answer.
Yeah, we will catch up on the questions after this fellows thing, and the discussion will continue. So let's just, yeah.
Sure.
Assalamu alaikum, everyone. Can you hear me?
Yes, we can hear you. Please go ahead.
Dr. Taha, there is an echo in your voice. Dr. Taha, there is an echo in your voice. Can you please mute the other system in the room? Yes, you can speak. Probably there are two systems in the same room.
Hold on. So, is the echo gone now?
No,
Yeah,
echo's
perfect.
gone. Yes,
Perfect.
So while we're waiting for him to get started, you know, there was a case from last time where there was an under-deployed stent, and you know, in acute situation, there's questions asked about whether we can use the rotablator in that scenario or not. And so thoughts from the panelists on that.
Like we never.
If you want to do a stentectomy and get the rota stuck,
Absolutely. So that was a question that we had over here. The other was a question we had regarding the Propofol. You know, a lot of questions regarding Propofol, that how you mix it in your solution that you use over here, Asad.
Just in 500, so in 500 cc, just like 1 to 2 cc Propofol.
So are you ready, Tahir?
Of the flush, I would just put in 1 to 2 cc.
Okay. Are you ready, Tahir?
Yes, I'm ready. Thank you for giving me the opportunity. My name is Dr. Tahir Saghir, and I'm Chief Fellow in Shifa International Hospital. And I was very fortunate. We will be discussing two cases which I assisted with Dr. Asaad Akbar Khan. And I was fortunate enough to be present in those cases, so I can just narrate the whole case, and it will be a good learning for all the fellows who are listening to us. So the first case is there was a 86-year-old gentleman, resident of Faridabad. He presented on 22nd of May this year, and he was presented and admitted via ER in the afternoon. So his presentation complaints were central typical chest pain, which happened 1 day ago. So it was the pain was for 1 hour duration, and the patient was initially managed at a local hospital. And when he came to us, he was asymptomatic, and the systemic inquiry was unremarkable. So if we talk about the comorbids, he was having long-standing diabetes, hypertension, CKD with a baseline creatinine of 2. He already had 3 PCI, underwent PCI thrice in last few years, 2006, 2007, and 2013. He was a known case of lymphoma post-COVID in February and had a neurogenic bladder. So he was non-smoker with a good socioeconomic status. These were the medicines that he was taking, which include statins, calcium channel blockers, and oral hypoglycemics. No known drug or food allergies. So when we did the vital signs, so they were pretty stable. Heart rate was already at 60s. There were no signs of heart failure on clinical examination. So our working diagnosis was acute coronary syndrome. So the initial ECG that was done at presentation, it shows that it was a sinus rhythm with first degree AV block, and there were significant ST elevations in the anterior leads and ST depressions in the lateral leads. So the lab workup that was done in the ER showed that his HP was 9.3. He had a creatinine of 2.1 with a clearance of 24 mL per minute. His CKMB was 26 and Prop5 was 25,000, and sugar was pretty well controlled. So this was the echo that was done. This is the short axis view at the papillary muscle level, which shows hypokinetic enteroseptum. Then this is the full chamber view, which again shows that there is a hypokinetic apical cap and the interior septum, apical septum. So patient was admitted to the CCU. He was started on dual antiplatelets, statins, IV heparin was initiated, nitrates were given. He was started on low dose beta blockers, and nephrology was called in because patient already had low creatinine clearance. So while he was here with us, there was no episode of chest pain. Patient was reviewed by the nephrologist, and they were given that if we proceed with the procedure or any intervention, it will be high risk as per contrast-induced nephropathy with the given risk of 26%. So given the whole scenario, it was decided by the consultants and all the team that he should be managed conservatively as he is asymptomatic and he already presented a little bit late to us. So we actually discharged this patient on dual antiplatelets, statins, beta blocker, and full anti-anginal therapy that could be offered. So the patient presented 3 days later on 25th of May with again a typical chest pain episode, which was 20 minutes duration and was relieved by sublingual nitroglycerin. At this presentation, patient was also having dyspnea with NYHA3 and orthopnea for last 1 day. So on examination, the significant thing was that he had bibasal crepitations and pedality. So the ECG was pretty much similar as of previous visit. His creatinine had jumped up. The BNP was significantly elevated. He had elevation in his CKMB from previously it was 26, now it was 31. Prop5 had jumped from 25,000 to 36,000. So it was clear that this is a new event. And the repeat echo showed that it had the similar hypokinetic walls. So this was the X-ray done at the presentation, which showed the bilateral CT angle blunting, which signifies mild, probably mild pleural effusions with interstitial prominence and hilar and central congestive changes. So the working diagnosis was reinfarction on medical therapy, decompensated heart failure, and AKI on CKD. So this time we discussed the patient, and it was we took him to the cath lab for angiogram. So this is the RAO caudal view, which shows critical distal left main disease. And we can see that there is critical, first of all, there is severe calcification. We can see the tram track appearance in both the vessels. And there is critical ostial LAD and ostial circ disease. So this is our cranial view, again showing severe calcification with moderate to severe diffuse disease in the distal LAD, and we can see collateral supplying from the left to the right system. So this is LO view, which shows probably a dominant RCA with the CTO at the mid level and faint retrograde filling from the left system. So in summary, it was an 86-year-old frail patient with advanced CKD having failed maximal medical therapy. He presented post-MI with acute pulmonary edema, and the coronary angiogram showed complex, severely calcified three-vessel disease. So the case of the patient was brought to the heart team of the hospital, and a multidisciplinary approach was adopted. Cardiothoracic surgeon was involved. Nephrology was again taken on board. Family was given the option of high-risk CABG, which they refused, and then it was told to the family that there is an option for rota-assisted high-risk PCI, for which they opted. So this is the PCI we started. We actually crossed the run-through wire through the LED. Then we can see that we are trying to pass the over-the-wire balloon. And then we later swapped the over-the-wire balloon with the rotafloppy. So here we took 1.75 burr, and you can see that initially there was a little bit hindrance crossing the lesion, but then the rotabur crossed smoothly through the lesion. And one might ask that we can see a temporary wire because the right system was dominant and there was CTO and it was being supplied to the left system, and we were doing the procedure on the left. So as a backup, we tried to pass the temporary wire. So now this is the final polishing run of the 1.75 bar. We can see that it's going through very smoothly. So now it's a routine practice. After every rota burr, we do a check injection. So we did that as well in this case, in which we can see there is no slow flow or no reflow, or there isn't any dissection of perforation. Now after rota, we did PTCA with 3.5 NC at 20 atmospheric pressure. And in the previous slide, we can also see that we have already crossed another wire into the circumflex, and we have also side-by-side cross run through wire into the LED along with the rotafloppy. So this is the PTCA of the left main to proximal LED. We have now planned to stent the So now, because the ostium of the circ is also was severely stenosed, so we were doing a PTCA of the circumflex. So this is the check injection after the PTCA to see for any complication. So now we have taken 3.5 into 34 millimeter stent, and we are trying to position it from left main to approximately mid LED. So we have deployed the stent in this slide. So this is after the deployment of stent, we are doing a check injection. So now this is post dilation after the stenting. We are doing a pot here with 5.4 NC, and this is the dot which we are doing with 3.5 NC. So when we did the pot, the patient became very uncomfortable and went into pulmonary edema. He sat up on the table. So we had to call up anesthesia as a backup, and the patient was giving IV Lasix on the table. Oxygen was attached. So these images were just to show that patient was very uncomfortable at that time. So this is the final result of the procedure that we did, which shows quite optimum results afterwards. And the total contrast used in this procedure was 45 to 50 ml. So post-PCI patient, as we already mentioned, was given Lasix on the table, oxygen was attached, low dose inotropes were started, and nephrology was again called to review the patient urgently. The first post-operative day, creatinine jumped up a little bit to 2.5. The patient still had a good urine output. We decided to start low-dose IV fluids.
Last minute.
And along with low-dose inotropes, hemodialysis was not yet considered because patient was producing good liver. Was going
you want to conclude?
last.
Okay.
So this is the post-procedure echo, which shows significant improvement in the LV contractility. And this is the post-MF view, which shows the post-PCI patient LV have improved significantly. So the key points, the take-home message from this procedure, that rotablation is a safe technique which can be used in high-risk patients. Heart team approach with adequate planning and preparation for possible complication, and in the presence of multidisciplinary expertise and experienced operators can improve the immediate and long-term outcome in high-risk patients. So in this particular case, we used a bigger burr with 0.5 to 0.6 burr to artery ratio for debulking in lesion preparation. And most importantly, judicious contrast use in advanced CKD cases is recommended to prevent post-procedure contrast-induced nephropathy.
I think, do you have another case?
Yes, there is one another case.
And this is the first case.
Okay, yeah. So if you want to do just like a quick, like 7-minute presentation of this case, then we can do discussion on both of them together, or we can just stop here and just do discussion on this one case for the sake of time. Can you wind it up in like 5 to 7 minutes, just quick?
We can do it quickly, huh?
Okay, let's do it quickly, and then we can do discussion on both together at the end, I guess. Okay.
Okay, so this patient was a 70-year-old, presented.
5-minute presentation. So
he presented with a typical chest pain, angina class 3 to 4. He again had diabetes and hypertension. EF was 40% at presentation. His PCI was attempted in KPK at a facility in KPK with a balloon uncrossable circ lesion, and they could not advance one of balloon after wire passage. So this was the ECG, which shows global ST changes.
yeah,
So this is the angiogram, which shows severe proximal LAD, calcified stenosis, and proximal circ, moderate to severe stenosis, and we can see dissection flap at the mid-circ level. So there is a dissection flap at the mid-circumflex level, and it looks calcified. So again, and it also seems that the circumflex, we already had an angiogram done from the other hospital, so we knew that the circumflex was dominant and RCO was non-obstructive, small, non-dominant artery. So we again passed the temporary wire. So what we did not know from the previous angiogram that LAD's ostium was also having critical, prox LAD was also having critical stenosis with slow flow. So that actually made us change our strategy. So again, after the angiogram, team was involved. Patient was given the option for high risk cabbage, and they opted for high risk rota-assisted PCR. So this was we are doing procedure on the LAD. We took 1.75 per and trying to cross the lesion. Then we did the PTCA with 3.5 NC. This is the post NC check injection. Then we have taken the stent and trying to position it. We want to avoid the ostium of LAD. So this is the spider view, in which we are again trying to position our stent. We want to keep it 1 millimeter away from the ostium. So now we have post-dilated our stent. We have deployed our stent, and this is after stent deployment. So this is post-dilation. So now this is the final result of LAD stenting. Now we'll proceed to the circumflex. So here we are trying to cross through the whisper, the dissected part, which we are not able to cross. So we took over the wire balloon and trying to cross the lesion, but yeah. So the run through went actually smoothly through the lesion, and then we took over the wire, and then it did not cross through the mid part. So we did a check injection after this attempt. Then we took Guidezilla and tried to cross Corsair, which went up to the mid part. And after that, we directly exchanged run through with the rotaflop. Initially, we took a smaller burr, which was 1.25, and you can see that there was hindrance crossing the dissected part. And then later on, it went through well. And now the rota 1.25 burr has crossed the dissected part, and we are doing the runs. So this is the check injection as per practice to look for slow flow, no reflow, perforation, or any dissection. Now we took the bigger burr size, which is 1.75, and trying to do the prox to mid circumflex. So at this point, patient developed the circ had slow flow. Patient that went into fast AFib, and his ST there was ST elevation on the cardiac monitor. So we gave IV nitroglycine and nitroprusside, and then we did now we did PTCA, high pressure PTCA. So this is the check injection after PTCA. We were not able to cross the stent, so we deep-seated the Guidezilla with the help of 3.5 NC, and then with the help of this, we were able to pass it. So in this, the stent was deployed. There was an overlapping stent that was again being placed, and it was deployed in this image. And now post.
All right, last minute or so, if we can wind it up then.
Yes, sir, we are about to finish. So this is the final result of our PCI to the circumflex. So at follow-up, patient has improved EF and improved symptoms. So just to conclude, while doing multi-vessel PCI, we must first address the lesion compromised blood or with the lesion which is more difficult to treat. In balloon uncrossable lesion, careful direct wiring with rotafloppy and use of smaller burr size can help make the lesion bleed. Subsequent rota with a bigger burr and PTCA with 1:1 sized NC balloon can help prepare the vascular bed for stenting. In a 2-burr rota case, second burr should only be used after checking for perforation or slow flow. So this is the data of the rota cases that we did in the last 24 months under supervision of Dr. Asaad Akbar Khan. The success rate was 100%. There were no major complications, no stroke, no perioperative death. The incidence of slow flow was 8%. Contrast-induced nephropathy was 5%. No perforation or dissection was occurred during the procedure. And in one patient, we did a temporary wire and there was wire-associated pericardial tamponade. Thank you.
Great cases, very interesting cases. And we have last 10 minutes, then we'll wind up the session. So I guess we'll start with thoughts from the panelists on these interesting cases. Dr. Farqad Alamgir.
I mean, the first case was an extreme case, really. You could see calcification everywhere. Not that uncommon in people with kidney disease. So I think you did the best, but wonders of angioplasty, how he tolerated you going across the circ with a blocked right. You know, it always surprises us how things behave. The second case, there was a mention about dissection in the circumflex. And just a word of caution for people who are starting or don't do as much cases as you do, that one should avoid dissection, and at least wait for at least 6 weeks if you can, if it is a must rotablator case. So, but excellent results, and your data is very, very impressive. I don't know how you managed so many cases. We can hardly get a burr. We have to, ring everywhere to find a burr.
Yeah, no, Boston Scientific has been kind, but in my initial 6 months, it was very hard to get a burr actually. Once they saw that we were using it frequently, I actually spoke to their management in the MENA region that we need more burrs. So we been lucky that we get these burrs in time, but I still, whenever I'm planning a case, I make sure we have that particular burr size in our lab. Ad hoc PCI, we would always have 1 to 2 burrs, but sometimes these regularly use 1 to 5 and 1.5 burrs. You don't really have them on the shelf. So you have to actually wait before you can get them. You're very right.
Just your comments on the dissection bit, because
dissection bit. So yes, I think what we did not mention was, so the angiography from outside hospital in that case showed that it was a dissection even before they attempted it. So it was a more like a chronic heel dissection, which was calcified, rather than a dissection that was caused at the outside facility. So that is why we did it. I totally agree, and that is why I even made him put the point in the end that you should not be doing it a dissection. If you have to do it, it has to be the smallest burr. Definitely, it was clearly you could see that even with a very deep-seated guidezilla, we could not even get the microcatheter across that part. So there was really no other option left other than using it. But the fact that it was more of a chronic heel dissection rather than an acute dissection was sort of made me confident that we will be okay. And lastly, I would never do it in an acute dissection for sure. Definitely 6 weeks, easily.
Just continuing on the dissection question, we come across the scenario quite often that, because of lack of resources, limitations of using rota, people start with the non-compliant balloon first aggressively, and that's not yielding the lesion, and then think of going to rota. So in that scenario, what is your cutoff looking at the angiogram in terms of, if there's obvious dissection, obviously you're not going to proceed with rota, but when you've ballooned it aggressively, you're going to have micro dissections. So from all the panelists there, how often you go doing in the rota? I guess if you have an IVUS, you can confirm the dissection. If there is a dissection or not, that is very helpful. But in real world scenario, you can't use IVUS and rota in the same case. But looking at the angiogram, there's no obvious dissection. Would you consider doing the rota in the same session if you've aggressively dilated the non-compliant balloon?
I think I'll answer for myself. So probably in an ideal setting, no, but in our setting, when we have limited resources, patient has already been convinced to give you money for the stent, and then you have already spoken to them. And if I'll make sure if I'll take two views, obviously two orthogonal views. If the flow is good and you cannot see any definite dissection, we have done these cases here, like where again, as you, Dr. Farqad said, we teamed up with the person who was doing it, or even in one or two of my own cases. But I think the message that should go out is that it should be pre-planned. And if you see that degree of calcium angiography, I think you should not do it. Ballooning before rota is never recommended because you have these micro dissections. You can always have this slow flow, and then you can actually get into this spiral of slow flow, and then your lesion might still not have yield, versus if you can just stop there and bring the patient back. So both options, I think that probably option is better.
All right, Usman, your thoughts?
So I agree completely. I try not to do ad hoc rota. It's if you haven't specifically consented the patient for rota, it's definitely a discussion worth having pre-procedure so that they understand the risks and what they're getting into. Having said that, if you balloon aggressively, if it's a grade 1 dissection that is not flow limiting, I will still go ahead and do rotablation. Generally, there is, obviously there's no randomized trial, but there's single center data from several centers that shows that as long as it's a non-flow limiting small dissection, you can still go ahead and rota it rather safely. About no reflow, what we've found useful, and a lot of it's getting more recognized and published now, is you can use intracoronary epinephrine for no reflow as well. And so you can use a cc, if you take a vial of epinephrine from the crash cart, use a cc from there, mix it with 10 cc's of saline, and then give 1 cc at a time through your guide. Or if you have a microcatheter down, that works really well for no reflow, especially in situations where the patients are hypertensive or can't tolerate nicardipine or other vasodilators. We actually published our series from AKU in the Pakistan Heart Journal. We did about 50 cases between 2017 and 19. And, Pakistani, we always say that our patients are very complex, but our syntax score was 32, which is higher than any other syntax score published in the Western literature. Over 70% of the patients were hypertensive, diabetic, had kidney disease. So these are very, the patients that the two patients that Dr. Asaad showed, complicated patients, high syntax score, high risk patients, and that's generally, our Pakistani data shows that that's the kind of patients that are coming through. But other than that, I think great job on those two cases. Worked out really well and had a fantastic result.
Dr. Asad Pathan?
I think just going on the dissection thing, as everybody said, and experienced operators have done in the presence of dissection, limited rotational atherectomy, and done it safely. There are options. You just do a very focal area. People have used guide extensions with rotablator. In situations, it can allow you to maintain a wire and a branch vessel while using a guide extension. And you can also use an extension and avoid the proximal dissected area and just burr where you need to focally. So if you get in a crunch situation where you're stuck doing, finishing the procedure, let's say you started with normal flow, you're foolish enough to try and balloon first, and now you have reduced flow, and then you can't dilate the lesions either. I think you fix it or send the patient to the OR. So in situations like this, I think you should go ahead and finish the job. So I don't think it's an absolute contraindication. Also, I think Asad, the two cases you showed, it seems like from your lecture, the burr selection was kind of different from what you preach, kind of aggressive burr selection sizes. Also, I think both cases with LV dysfunction, especially the first one, high risk of no reflow. And if that happened with that kind of anatomy, he would crash and burn. I think you could make, even in Pakistan, you could make a reasonable case, if possible, to put a prophylactic balloon pump from the beginning before proceeding. I would have perhaps considered burring the circumflex ostium also. and also probably IVUS in between to make sure that you fractured the calcium before going in with balloon and stent. And also in the second case, I think maybe dominant circ can already flow down and you're treating the LAD with flow down. Maybe perhaps, at least for the beginner, I think consider, I know cost is an issue, but patient safety is foremost. So perhaps some of these cases should be staged. Maybe treat one vessel one day and come back and take care of it another day. I think it's a lot simpler to talk to the family about cost and coming back and staging rather than talking to them about a bad outcome. So I think all of these things need to be considered. Most of the times we get away with things, but prevention is always better than taking care of these issues.
Just one quick comment. So in the first case, in the second case, the LED was a 3.5 vessel. So we used a 175 burr, which is like 0.5 to 0.5 burr to artery ratio. In the circumflex area, we used a 125 burr, and just for the proximal part, we used a 175 burr because it was already open. And for the first case where we only did the LED, it was a huge LED. So you can see even with the 3.5 stent, we needed to post dilate with a bigger balloon. And in that one as well, we used a 175 burr. So we did not size any burr more than 0.5 burr to artery ratio in either of the two cases. The proximal circ in the second case.
I think these days, I think most atherectomy expert would probably, if you have to use two burrs, so they would still start with a 125 or a 1.5, and then depending on the need. So, but I understand the dynamics in Pakistan and the cost involved. But I think we keep talking about the cost, but I think patient safety and good outcome probably supersedes everything else. I think that's what we should always have in mind, and cost and other considerations should be secondary. But excellent job. I know you had the right thought in mind and got the job done. Great work.
Just a quick question: is anyone re-sterilizing rota burrs? Is that for reusing? What's the?
That cannot
are you
be
allowed to talk about that on this forum?
We cannot talk in a different WhatsApp group.
or continue that discussion in the WhatsApp group.
This cannot be done over here. Discussion, but not recommended at all.
Never do it in Pakistan. Never.
Okay.
And yes.
We've tried it, and it's frustrating because more than half the time the burr doesn't work when you try and use it because it's difficult to flush them, but occasionally you get away with it. I think we have to talk about these things because a lot of times it's required, but proper re-sterilization and cleaning it and all. Occasionally you can reuse it. Nauman, I need to leave because I have another session I'm actually speaking in.
We are finishing up. We are finishing up last minute. I just had a question. Thank you very much for joining, and really appreciate your interesting comments and useful comments. Thank you. So I guess we'll wind up the session. There's a question regarding stuck rota and how to deal with that, and how often any of you have had a stuck rota in your cases. Just quick thought. Actually, Professor Nadeem Rizvi, if you're in the session, you had a case recently that you were discussing where the rota got stuck. So
yes, I think I think it was the first case in a private sector, and I think it was my mistake as well, and made the classical mistake of taking the pedal off because I was concentrating on something else, and the rota got stuck in the mid RCA, and we somehow managed to get it out by putting a balloon on the side and a small balloon. But this just shows you have to have a team. I was trying to teach my fellow at the same time with a new case in a new center, and these things do happen. My only question is that we do use small rota burrs, usually 1.25, not more than 1.5, because using a 6 French. But just to clarify, we do actually, once you use a 1.25 and modify the initial, break the intima, then I normally do use an NC balloon before putting a stent in. So I think just to clarify with Asaad, that we do normally do, unless you're using a 1.752 and then stent directly, I think there should be, in our case in Pakistan, when we're using smaller burrs, then we should do an NC before putting a stent in. I just want to
that is a standard practice for me. Even if in all the cases that were shown, even after the 175 burr, we did NC balloon, 1-to-1 size NC balloon, high pressure, to make sure the plaque is fully prepared and the bed is fully prepared, always.
And if there is a dissection on using an NC, which micro dissections do happen, that does not really mean that you cannot put a stent in or something. I think the dissections do happen once you use an NC large 1-to-1 balloon, and before putting a stent in. Just to clarify, because I think that the initial impression was that we should not do this.
Always. I think the question was that if we have already done an NC balloon, can we do a rota after that? So that's what we were saying. We should not be. It should not be a practice. But after rota ablation, I always put an NC 1-to-1 size NC, high pressure, make sure everything is fully expanded before you go in with the stent.
And with this, I think we'll wind up a session. Thank you everyone for joining us. Really had a great time and very useful. Thank you.
Thank you.
Have a nice
Thank
day.
you. Thank you. Assalamu alaikum, everyone.
Assam.
Yeah.